Prognosis in post-cardiac arrest survivors, even after resume of spontaneous circulation, is poor, with estimated survival rates of around 40%. 80% of these patients dies from post-anoxic encephalopathy, so brain damage. And this is caused by a two-hit model, the first hit being the no-flow and the low-flow time before achieving ROSC, and the second hit being hypoperfusion injury during ICU stay. And current guidelines actually recommend targeting a mean arterial pressure of 65 millimeters of mercury in these patients. However, we previously showed that patients treated according to the guidelines with a mean arterial pressure of 65 millimeters of mercury, they experience a profound drop of the cerebral perfusion and oxygenation during the first 12 hours of ICU stay. So if 65 millimeters of mercury may not be enough to perfuse the brain, what then is the optimal blood pressure target in these patients? And we previously showed in an observational study that a blood pressure of 100 millimeters of mercury is associated with optimal cerebral perfusion, while lower blood pressures result in suboptimal cerebral perfusion, and higher blood pressures are associated with excessive afterload and reduction in stroke volume and in cerebral perfusion. So the aim of the Neuroprotect trial was to investigate whether early goal-directed hemodynamic optimization, which means a mean arterial pressure between 85 and 100 millimeters of mercury and a mixed venous oxygen saturation between 65 and 75% by additional fluids, inotropes, and vasopressive agents during the first 36 hours of ICU stay, is safe, is able to improve cerebral perfusion and oxygenation, able to reduce anoxic brain damage on diffusion-weighted MRI, and able to improve functional outcome at 180 days. So it's a multi-center, investigator-driven trial in which patients were randomized according to the presence of an initial shockable rhythm to either early goal-directed hemodynamic optimization or a mean arterial pressure of 65 millimeters of mercury. Although the responsible ICU team was fully aware of treatment assignments, all outcome assessors, including neurologists performing neuroprognostication, radiologists performing MRI analysis, and statisticians, remained completely blinded. The trial was monitored under the supervision of Fabio Tacconi and sponsored by a grant from the Flemish government. Basically, it's an all-comers trial, including unconscious post-cardiac arrest survivors who had restoration of spontaneous circulation for 20 minutes. Excluding patients with refractory cardiogenic shock, previous major larger stroke, and MRI incompatible devices. So first of all, early goal-directed hemodynamic optimization was completely safe, despite the use of higher doses of inotropes and vasopressive agents in patients assigned to receive the therapy. Adverse event rates were significantly lower, with a 60% relative risk reduction in the rates of recurrent cardiac arrest. So future post-hoc analysis will need to explore the hypothesis that improving coronary perfusion may result in a faster relief of the arrhythmogenic substrate, and this may explain these findings. Second of all, the therapy was able to improve cerebral perfusion and cerebral oxygenation, thereby for the first time providing the proof of concept for this therapy. And we could also not show an improvement in functional outcome at 180 days. First of all, it's safe and it's able to improve cerebral perfusion and oxygenation. However, we could not show a reduction in the extent of anoxic brain damage on diffusion-weighted MRI and an improvement in functional outcome at 180 days. So should we, based on this trial, stop thinking that improving brain oxygenation may improve functional outcome of these patients? I don't think so. First of all, diffusion-weighted MRI had a poor accuracy to predict prognosis at 180 days. So thereby not only questioning the validity of our primary endpoint, but also the added value of using diffusion-weighted MRI for neuroprognostication in daily clinical practice. Second of all, baseline brain damage was quite extensive in our patients, rendering the potential benefit for interventions in the ICU rather limited. And I think there were some trends towards favorable outcome that mandated the need for an outcome trial in these patients.